All right. Hi, everyone. Let's welcome Dr. Gilbert back for her second lecture in summer core lecture series on sepsis.
Okay. Okay. All right, guys. Hello again. Nice to see everyone. I've given this talk for years and years and years, and I give it also to the MICU lecture series, and I give a version to the sub-Is, and I give another version to the second years. And so I have a lot of sepsis talks, and I was just telling Magda, every year there's so much information, and I try to cram it all into this talk, and there's really just too much to go over in an hour. So I'm going to try to hit the basics. And of course, if anybody has any questions, just find me afterwards. But I'm going to try to get through a lot today. We're going to talk about definitions because, as you know, these have changed over the recent years. Talk about how to recognize the deteriorating patient. We'll spend the bulk of the time talking about the SEP1 bundle, and then end up by kind of talking about this new theory about sepsis phenotypes. So definitions. As you guys know, the first definitions for sepsis came out in 1991, and then they were kind of tailored but minimally changed in 2001 to include infection with 2 or more SIRS criteria is sepsis, sepsis plus organ dysfunction is severe sepsis, and then if you have hypotension that doesn't respond to fluids, that's septic shock. But a lot of people were upset about this form of the definition because they didn't like SIRS criteria, because you can certainly have SIRS without infection, and you can certainly have infection without SIRS. And so a lot of controversy about the SIRS criteria. So then in 2016, the new definitions, the sepsis 3 definitions came out, right? And this was basically saying sepsis is not just infection plus SIRS. What's important to understand is the host response to that infection, right? Because some people will get infected and will be totally fine, and then other people will get infection and they will die, right? And so we really need to identify those people who are going to be at risk for dying. And that's because when a pathogen invades the body, you can have activation of both a pro-inflammatory response and an anti-inflammatory response. Too much inflammation can lead to organ dysfunction and tissue damage, injury, and death. Not enough inflammation, too much of that anti-inflammatory response can lead to secondary infection. And so what you want is a balance between the pro-inflammatory and the anti-inflammatory response, because that will lead to the best outcome. And so what we wanted to do was not to identify every single patient who has infection, but to identify those infected patients who are really sick, the patients who are at highest risk for dying. And so that's why they introduced these new definitions in 2016. They got rid of the SIRS criteria, and they said, if you're septic, you are infected, and you have organ dysfunction as defined by a SOFA score of 2 or greater. And so they changed the definition to say you have organ dysfunction caused by a dysregulated response to infection with a threat to survival. It's that dysregulated response to infection that's important here. They eliminated severe sepsis because right now you're septic with organ dysfunction. That's now just sepsis. And then this new septic shock definition, a little bit different, where they said that you are septic and you have hypotension and your lactate is over 2 despite fluids. So that lactate over 2 despite fluids, that's a new part. So again, the key about sepsis is recognizing when your patient is deteriorating. This is a snapshot of a bunch of variables of a patient who was septic and then developed organ dysfunction and then went on to develop septic shock. And you can see that about 12 hours before the onset of septic shock, there was a change, right? There was some sort of change in their vital signs in their labs. And if you can identify the patient at that point, then maybe you could start your management early and prevent them from progressing to organ dysfunction and shock. And so which vital signs should we pay attention to? What's the best predictor of mortality? This was a study that was done that looked at a bunch of patients who went on to die from sepsis, and they found that there were 6 independent mortality predictors: a change in level of consciousness, drop in blood pressure, change in respiratory rate, or SAT, with the change in the respiratory rate being most predictive. So using this information, the sepsis 3 guidelines introduced something called the QSOFA, the quick SOFA. Now, you guys have probably heard of this, and there's a lot of confusion about QSOFA. QSOFA does not define sepsis. It's not like it's the new SIRS, right? QSOFA is used to identify the deteriorating patient among your infected patients. So if you have an infected patient on the wards who has a UTI, but she's fine. And then you go in the next day and now she's breathing at 30, or she's altered, or her blood pressure's dropped. She's at risk for deterioration. So that's a patient you need to watch closer. So again, QSOFA does not define sepsis. QSOFA is a tool to identify those who are at risk for deterioration. So if you have 2 or more QSOFA criteria, respiratory rate greater than 22, altered mental status, or a drop in your blood pressure less than 100, you're at risk for deterioration. This has been shown by that group that introduced the Sepsis 3 guidelines. QSOFA is better than SIRS or SOFA for identifying patients who are at risk for dying outside the ICU. But while while SIRS is not specific, QSOFA is not sensitive. If you waited for all of your infected patients on the wards to meet QSOFA criteria before you send them to the ICU, you're missing some sick patients. So it's just a tool that you can use. Something that we have here at Loyola, the residents probably are aware of this, interns may not be as much, but we have something that runs in the background of EPIC called the Modified Early Warning System, or MUSE. Every time a vital sign is inserted into EPIC, a score is generated. The more abnormal that vital sign, the higher that score. So temperature, pulse, respiratory rate, blood pressure, and level of consciousness. So in this patient, they're a little bit febrile, they're a little bit tachypnic, they're altered, they have a MUSE of 5. And when a MUSE of 5 is triggered, the nurses are supposed to call a rapid response. Rapid responses were introduced a long time ago to try to reduce the unplanned ICU admission, unplanned cardiac arrest. Multiple studies looking at rapid responses have not shown that this actually happens. This is the biggest trial, probably one of the bigger trials, the Merit trial in 2005, where they randomized hospitals in Australia to either be a rapid response hospital, they called it a MET, or a normal hospital, which didn't have a rapid response team. And you can see when looking at the primary outcome, no difference in cardiac arrest, unplanned ICU admission, or unexpected death between the rapid response hospital and the control hospital. So your next question is probably then, why do we have rapid responses? It's actually nice here at Loyola because when you call a rapid response, an ICU nurse goes, patient placement's alerted, they find an ICU bed immediately for that patient. So it just gets a second pair of eyes on the patient and gets a bed ready just in case they need to be urgently transferred. So although it doesn't probably reduce our mortality or reduce our unplanned ICU admissions, it certainly is a help for the nurses and for the inpatient ward teams. But a MUSE of 5 is not specific for sepsis. When we first introduced this, the nurses used to call this a sepsis screen. It is not a sepsis screen. You can certainly fire a MUSE if you're withdrawing from alcohol or an AFib with RVR, but it's something that you should, if you go to a RRT for a positive MUSE, then sepsis should be on your brain, and you should think, could this patient be septic, and then start your management right away. So that brings us to the management of sepsis. You guys, we can't talk about the management of sepsis without at least mentioning this paper. This is the early goal-directed therapy trial that was published in 2001, now 20 years ago, by Dr. Rivers. And what he did was he took septic patients, he randomized them to a control group and an intervention group. In the control group, he gave them antibiotics, he gave them a central line, he followed their CVP. If their CVP was less than 8, he gave them fluids. If it remained less than 8 despite fluids, he started them on pressors, and to maintain a MAP of more than 65. That was the control group. In the intervention group, he went a step further. He had a special central line that monitored a mixed venous oxygen saturation. If it was less than 70%, he gave them blood. And if it remained less than 70%, he gave them dobutamine. So that was early goal-directed therapy. This was what everybody did back then, because in this trial, the intervention group had a mortality reduction of 15%, which was huge for sepsis, right? So I remember when I was an intern and I was a resident in the mid-2000s, this was posted in our ER. It was blown up, big poster. This is what we all did. But a lot of people had issues with this trial for a variety of reasons. So it was repeated and compared to usual care 3 times: PROMISE, PROCESS, and ARISE in 2014, 2015. And they found no difference comparing early goal-directed therapy to usual care in 2014, 2015. Now, usual care had changed, right? Because this is all what we were doing. We were giving patients fluids early. We were giving them antibiotics early. We were recognizing them early. That's what early goal-directed therapy, I think it made us all change the way we manage sepsis by recognizing it early and treating people early. So, but CVP, mixed venous oxygen saturation fell out of favor. and new management bundles were introduced in 2015 called the SEP1 bundle. Again, really re-emphasizing that sepsis is a medical emergency. You need to recognize it early and treat it early. So in 3 hours, for the first 3 hours, you have to get blood cultures, get a lactate, give antibiotics, and give fluids if the patient is hypotensive. And then the 6-hour bundle is if the initial lactate was over 2, repeat it, go back and reassess the tissue perfusion in your patient, and then start vasopressors if they're still hypotensive despite fluids. So we're going to go through each component of this bundle and talk about the data behind it. So obviously blood cultures, that's the first part. You want to get blood cultures before antibiotics so that you can increase the yield of finding an organism. But antibiotics, this is the most important part of the bundle. This is the only part of the bundle that has been shown to reduce mortality. This is a study out of Chris Seymour's group where they showed that the sooner you complete the 3-hour bundle, the decrease in mortality. And if you look at the component of the bundle that is driving that reduction in mortality, it's the antibiotics. So if you walk away from one thing in this lecture, antibiotics, do not delay. If you think your patient's infected and you go see them in the morning, don't wait until your attending gets there at 10 o'clock in the morning to start antibiotics. Give them a dose of antibiotics. We have a sepsis order set. Every single antibiotic you can think of is on there. It's just broken down by organ system. So if you have a suspected abdominal source to your of your infection, all the different abdominal antibiotics are on there. Use the sepsis order set. It gets your antibiotics quickly. I think you get 3 days for free. So use this and give your antibiotics early. Do not delay. Serum lactate. Lactate goes up in sepsis for a variety of reasons. It's not just tissue hypoxia. I'm sure we've all seen patients who are not hypotensive, who are not hypoxic, who have a high lactate, right? And that's because of impaired oxygen extraction. That's because sepsis increases your metabolic rate and also stimulates intrinsic catecholamines, which lead to glycolysis, which leads to lactate. And then, of course, sepsis can lead to organ dysfunction like renal or hepatic dysfunction, which slows your lactate clearance. So lots of reasons why your lactate can be high in sepsis. And we all know the higher lactate, the higher mortality, right? I don't think anybody in this room has ever seen somebody with a lactate of like 18 survive sepsis, right? This was a recent study out of from February 2021 that shows our 6-hour lactate or our lactate clearance actually may be a better predictor of mortality than our initial lactate. Do I have a little laser pointer? I do. So this dotted line right here is our 6-hour lactate followed by lactate clearance. And this group found that if your 6-hour lactate is more than 3.5, that's a good cutoff for predicting mortality, or your lactate clearance of 6-hour lactate clearance of less than 24.4% predicts mortality. But regardless of how you look at it, the higher your lactate, the higher mortality. If somebody comes in with a lactate of 8 and their 6-hour lactate is now 2, well, that patient probably is going to do okay. Versus if their initial lactate is 8 and now it goes to 12, that patient has a higher chance that they're not going to make it. Okay, the 30 cc's per kilo fluid bolus. This I wanted to spend a little bit of time on just because it is so controversial. So anytime you think about a drug, the pharmacy literature has the 4 Ds: drug, dosing, duration, and de-escalation. So you can take this and apply it to fluids. So let's first talk about the drug. What type of fluid should we use in sepsis? The recommendation is for crystalloid. For crystalloid, you have 3 options: normal saline, LR, or plasmolite. You can see the makeup of these different types of fluids here. Interestingly, normal saline is the cheapest, plasmolite's the most expensive at $12 a liter. Plasmolite and LR are considered your balanced crystalloids. They're thought to be more physiologic than normal saline, which is just half sodium, half chloride. So there's been a lot of talk about using your balanced crystalloids over your normal saline because normal saline can lead to this hyperchloremic non-gap metabolic acidosis, which if you were at my acid-base lecture, you know is a bad thing. So why is it a bad thing? So acidemia can lead to inflammation and can lead to coagulopathy, and hyperchloremia can actually induce vasoconstriction within that afferent arteriole, causing reduced GFR and acute kidney injury. So the thought is, if you're already septic or if you're already acidemic from your sepsis, then adding normal saline to that patient may not be a good idea. Lots of different trials looking at this. This graphic demonstrates 2 of the trials. This is the SALT-ED trial and the SMART trial. The SALT-ED trial and the SMART trial both took balanced crystalloids, so LR and plasmolite, and compared them to normal saline. They did monthly crossovers. SALT ED was done in the ER. SMART was done in the ICU, both at Vanderbilt. And what you can see here is that they looked at this composite outcome of death, need for dialysis, or persistent AKI. And in both the SALT ED and in the SMART trial, there was a significant reduction in that primary outcome favoring the balanced crystalloid group, but it wasn't that dramatic, right? 15 versus 14%, 5 versus 4%. And the primary outcome in the SALT ED trial was hospital-free days, and there was no significant difference. So my takeaway from these trials looking at normal saline versus balanced crystalloids is if you have to give a liter or two of fluid, it doesn't matter. Normal saline, LR, plasmolite, doesn't matter. If you have to give a lot of fluid, if the patient's already in renal failure or has a history of need for dialysis, probably the balanced crystalloids is the way to go rather than normal saline because of that risk. Okay, the dose, 30 cc's per kilo. Where does this come from? The thought is that this recommended dose comes from the PROMISE, PROCESS, and ARISE trials, because if you look, before these patients were randomized in each group, they all got about 30 cc's per kilo. So it's thought that that's where that recommendation came from. This is looking at a bunch of sepsis trials where you can see that they got anywhere between 2 to about 6 liters of fluid, which is actually a little bit more than the 30 cc's per kilo, which comes out to about 2 to 3 liters of fluid. When you look at these older sepsis trials, here's the Rivers trial from 2001, here's PROMISE, PROCESS, and ARISE. You can see that it looks like this is mortality. The more fluid you get, the lower your mortality. Although here you don't see that mortality change, but they get about the same amount of fluid in each of the control and the intervention arm. So does fluids reduce mortality? Why is this part of the bundle? This was again that Chris Seymour study looking at how quickly you could complete the 3-hour bundle, and it was the improvement. It was the speed of giving the antibiotics that was leading to that reduction. If you look at how quickly they completed that fluid bolus, no change in mortality. Here's another study. This is an observational cohort study looking at 1,000 patients with severe sepsis or septic shock. They found that in this study, more than 50% of the patients did not meet that 3-hour fluid requirement. They did not get the 30 cc's per kilo. Either it wasn't ordered or it was stopped prematurely. Obviously, lower compliance was noted in the group of patients who had CKD, heart failure, or liver disease, and they were inpatient versus in the ER when they were diagnosed with their sepsis. But if you looked at the two groups, it didn't matter if you got fluids or not, there was no difference in mortality, whether you completed that 3-hour bundle or didn't. So then if they're not reducing mortality, are they potentially harmful? There's 2 studies that looked at this and found that there was an actual harm to giving fluids. These are both out of Africa, so may not be applicable to our patient population. The FEAST trial is looking at children in Africa with severe febrile illness and evidence of hypoperfusion. They were randomized to one of 3 groups: no bolus, 20 cc's per kilo of albumin, or 20 cc's per kilo of saline. And they actually had to stop this trial early because there was a significant increase in mortality in the children who were getting albumin or a saline bolus compared to no bolus at 48 hours. 10% mortality versus 7% mortality in the no bolus group. So this study was stopped early because of a significant mortality in the fluid bolus group. And then this was out of Zambia. This was looking at adults with sepsis, and they randomized them to usual care, which was just antibiotics and fluids given at the physician discretion, versus a sepsis protocol, which is 2 liters given over an hour, followed by 2 liters over the next 4 hours. And you can see almost immediately a dramatic increase in mortality in the group that got sepsis protocol. So that just goes to show that you just can't take one fluid bolus and apply it to every single patient in sepsis. You really have to kind of use your clinical judgment, right? If somebody has an albumin of 1 and they're already severely volume overloaded, then maybe that patient is not a good candidate for a fluid bolus of 30 cc's per kilo. But there are some patients who respond to fluids, right? So if you guys got septic, I would give you a lot of fluids because you are volume down, you're having capillary leak, you're going to need fluids. But the next D is duration, right? The timing of those fluids. The sooner you give the fluids, the better chance that that patient's going to respond. This is adapted from the Andromeda shock trial, which we'll talk about in a little bit. And you can see that the best chance of that you're getting to find a fluid responder is if you give that fluids early. So 57% of patients will have a good response to fluids if you give it to within the first hour or two of shock. And by respond, I mean their blood pressure gets better, their urine output picks up, they start to wake up, they have an improvement in their cardiac index or cardiac output. So some patients do benefit from fluids. But how well you respond to fluids depends on the clinical scenario and the type of fluid. If you have somebody who's in hypovolemic shock and you give them 2 liters of LR, there's a good chance that they're going to have a dramatic expansion of their plasma volume, and that response is going to last for a while. That's compared to if you give the same bolus to a conscious volunteer and they have a minimal response. And that's because our capillaries are leaky at baseline. And so if you give a bolus to a healthy volunteer, 70% of that fluid extravasates within the first 30 minutes. And so if you think about a septic patient who has this leaky capillaries, the longer you wait to give that fluid, the leakier they are and the less chance they're going to hold on to that fluid and be a fluid responder. This was a study that looked at patient factors that were most predictive of fluid non-responsiveness. And you can see here, there's a variety of factors, but the most predictive factor was timing to fluid initiation. So if you waited more than 2 hours to start fluids from the onset of shock, there's a better chance that that patient's not going to respond. Similarly, this is another study looking at the timing to initiation of fluids. Again, if you wait to give fluids, there's a better chance that patient ends up in the ICU on a ventilator and has a higher chance of death. This is in contrast to the study, the Chris Seymour study, where it looked at completion of the fluid bolus, where it showed no change in mortality. This is looking at timing to initiation of the fluid bolus, so a little bit different. So this makes me think that there is this kind of golden hour of resuscitation, right? If you have somebody who's hypotensive, they should be started on fluids almost immediately to really, again, get a better chance of finding a patient who's going to be fluid responsive, rather than waiting and trying to figure out if they need the fluids or if they don't need the fluids, or maybe they got too much of their metoprolol. Just give them the fluids, because if you wait, there's a higher chance that they're not going to respond. And then the final D is de-escalation. It's not the fluid balance at 24 hours that's associated with mortality. It's a higher fluid balance at 72 hours that's associated with mortality. So if you get your patient resuscitated and they are looking good and they're coming down on their pressors, then it's a good time to start them on Lasix to get that extra fluid off, because again, the higher your fluid balance is, the higher chance that they're going to die in the ICU. So de-escalation, using Lasix to get that extra fluid off. So again, remember the 4 Ds with fluids. Drug, balanced crystalloid is preferred, and that's usually going to be LR rather than Plasma-Lyte, because Plasma-Lyte's a little bit more expensive. Dosing, 30 cc's per kilo. That's going to be about 2 to 3 liters for most of our patients, but it may not be for everyone. Somebody who's already in right heart failure, your cirrhotic whose albumin is 1 and they're already massively volume overloaded. Those are the patients who probably shouldn't get that full bolus, and that's okay. You're not going to meet the CMS 3 to 6 hour requirement. But if you're using your clinical judgment and you're doing what's best for the patient, that's okay. Duration, timing of fluid should be early. The longer you wait to start the fluids, the less likely they are that they're going to respond. And then de-escalation, once the patient is hemodynamically resuscitated, start them on Lasix to get that fluid off. Okay, so that's the 3 hour bundle. Any questions on the 3 hour bundle? Okay. Moving on, the 6 hour bundle. Repeat that lactate if that initial lactate was over 2. We talked about this following lactate. Lactate clearance can be a predictor of mortality. And then this next part, if persistent hypotension after fluids or your initial lactate's over 4, go back and repeat your volume status and tissue perfusion assessment. Now, the way they say to do this is using a physical exam or CVP or other bedside maneuvers, but we all know that our physical exam, and following CVP is a really poor indicator of volume status, right? It's been shown in multiple studies that it's just not accurate. So are there other ways to assess tissue perfusion? Certainly, again, lactate clearance, looking to see if you have adequately resuscitated your patient, looking at, that 6 hour lactate clearance of around 20% may be a good way to assess your perfusion. But there's a lot of things that affect lactate, especially if your patient's in renal failure or hepatic failure and not clearing the lactate. Maybe you are doing a good job of resuscitating that patient, but they're just not clearing it for other reasons, because there's a lot of confounders. So this was a trial. This is that Andromeda shock trial where they compared lactate clearance to just a very easy bedside maneuver of assessing capillary refill. So Capillary refill is supposed to be the best physical exam finding to assess your perfusion or in your volume status. So the way you check capillary refill, you hold on to the pulp of your finger for 10 seconds, and then you let go and you measure how quickly it takes for your finger to turn back to pink. Less than 3 seconds is normal. So what they did is they randomized these patients in the ICU with septic shock to normalizing cap refill, less than 3 seconds, or targeting a lactate clearance of greater than 20% over 2 hours. And they followed this resuscitation protocol. And what they found was that when you compared the lactate clearance group to the peripheral perfusion group, the cap refill group, no difference in mortality, indicating that just following a simple bedside test can be just as good as following frequent lactates to indicate whether you're doing a good job resuscitating your patient. So again, something really easy to do at the bedside that you can try to normalize that and follow a resuscitation protocol using that method. And then finally, the final component of the 6-hour bundle is if your patient is persistently hypotensive despite fluids, then you've started that on vasopressors. And our MAP goal for vasopressors, we usually say more than 65, right? But then this very cute trial came out called the 65 trial. This came out in JAMA last year. What they did was they took patients over the age of 65 in 65 ICUs, and they randomized them to permissive hypotension, which is a MAP goal of 60 to 65 versus usual care. And what they found was that there was no difference in mortality when you compared usual care to targeting a MAP goal of 60 to 65. And what they found when they looked at the average MAP in each of the groups, in the usual care, the MAP goal is about 72 versus the average MAP obtained in the permissive hypotension group was 66. So it just goes to show if you give the nurses a range of about 60 to 65, they're going to overshoot a little bit because they don't want to be in the room every 5 seconds adjusting the vasopressor. So I've started telling the nurses 60 to 65. So they kind of are aiming for that low 65 range. And there's no difference in mortality. And this is even in older patients who you would think would need a higher MAP goal, no difference. So I now say 60 to 65 for most of my patients. Okay, let's talk about pressors. So here are different options for administering vasopressors. Are any of these a contraindication? Any of these that you cannot run pressors through? No, you can run pressors through all of these. IO, central line, PICC line, cordis, those are fine. And so are peripherals, right? The concern about running pressors through a peripheral line is extravasation, right? If your IV blows and you get norepinephrine in your arm, your skin falls off and the patient dies. And that's not true, right? And so this is a study that was published a couple of years ago looking at 202 patients who had peripheral administered pressors. And they found that of those 202 patients, only 8 had an extravasation event. And when you looked at the injury grade, it was 1 to 2, that none of them had severe injury. They were all managed conservatively, and most of them had pressors restarted peripherally. So I just say this because I think there's this kind of myth that within academia, we are never allowed to run pressors peripherally. And that is not true. So if you're on night float and you're struggling with a central line for 2 hours and you've got 3 admissions waiting in the ER and you're like, I got to get the central line in because I can't run Levophed peripherally, you can, and it's okay. Leave the central line for the day team, go down and do your admissions. It's okay. In fact, if you have a good IV, like larger than a 20, right? So 18 or 16 in a really good safe spot, it's totally fine. Now, I'm not saying that you should run Levophed and vasopressin and phenylephrine through a vein for a week. I mean, you have 24 hours really that you can run something peripherally in a good vein. If it does extravasate, there's a good chance it's going to be fine. The nurses do have an extravasation protocol that they can pull up and walk you through. So don't worry, just don't kill yourself trying to get a central line in somebody overnight if you've got other stuff to do. That's what I'm just trying to say. Okay, what are our pressor options? Our pressor of choice is norepinephrine, right? Or Levophed. Levophed works on the alpha receptors to cause vasoconstriction and also works on the beta-1 receptors to improve contractility. As a side effect, the beta-1 receptors can cause an increased heart rate, but that's okay. Our second line pressor, if you're still needing a lot of Levophed to maintain your MAP goal, is either vasopressin or epinephrine. We tend to do vasopressin first here, right? Adding vasopressin to Levophed does not reduce mortality, but it allows us to turn down the dose of Levophed And when we turn down the dose of Levophed, there's fewer arrhythmias. So that's why we usually do vasopressin. The dose is 0.03. We turn it on, we turn it off. There's no titrating. If they're on norepinephrine and they're on vasopressin and you still need a pressor, then our next one is epinephrine, again, with some beta-1 activity. Phenylephrine is not my first line or my second line or my third line pressor. It only acts on the alpha receptor. It does not have any beta activity. And the reason that we want beta activity is because of sepsis-induced cardiomyopathy. This is something that we see a lot of in our septic patients. The definition of sepsis-induced cardiomyopathy varies within the literature, but in general, it's global biventricular dysfunction with a drop in the ejection fraction. It's acute, but reversible within about a week, week and a half, and there's no other etiology for it. The prevalence really varies depending on the definition, but I've seen up to 70% in some of the papers. So a lot of patients potentially with this cardiomyopathy. So if you see somebody with any of these risk factors, male sex, younger age, higher lactate, that patient's at risk for the sepsis-induced cardiomyopathy, and they're going to need that beta from the epi or from the Levophed, and that patient should not be on phenylephrine. This was a paper that was just accepted a couple of months ago in the Blue Journal. They only followed 16 patients, but what they did was they got an echo before pressors were started and then got an echo every 10 minutes after vasopressors were started. A couple shocking things from this trial. 81% of these patients had systolic dysfunction on their initial echo. So 6 of them had pre-existing systolic dysfunction. 7 of them had new systolic dysfunction, which is a lot out of 16. And if you look at what happened when they started the vasopressor, the norepinephrine, they had improvement in their LV and their RV systolic function. So again, it really is, I like Levophed. I like that beta-1 activity. So that's why I prefer Levophed over phenylephrine. And so if Levophed has so much of this benefit, then why don't we start it early? This is the sensor trial that was randomizing patients with septic shock to early, and by early, I mean within an hour of the onset of shock, early norepinephrine versus placebo. So these patients were admitted, they got antibiotics, they got fluids, but within an hour of their shock, they got started on either norepinephrine or placebo. And then if they remain hypotensive despite their fluids and their study infusion, they got started on open label vasopressors. Their primary outcome was shock control, meaning a normalization of their blood pressure and clearance of their lactate. 76% of those in the norepinephrine group had shock control by 6 hours versus only 50% in the control group. No difference in mortality, but the interesting part of this study was this. There was lower incidence of cardiogenic pulmonary edema in the norepinephrine group. Again, going back to the fact that if you give norepinephrine, it's going to have that beta-1 activity. If you have sepsis-induced cardiomyopathy, then it improves your pump, it improves your forward flow, reduction in pulmonary edema. The other thing was interesting, even though norepinephrine has that beta-1 activity, lower arrhythmias in the norepinephrine group. So something to think about. And again, there should be no delay in norepinephrine, right? Because if you can run it peripherally, I just told you you can run it peripherally, you should be able to start it as soon as you think this patient needs it, rather than waiting to try to get a central line in. 2 other pressors I should probably mention, dopamine and dobutamine. Both are extremely arrhythmogenic. Dopamine has a lot of beta-1 activity. So a lot of arrhythmia is really only reserved for those patients who have relative bradycardia. And then dobutamine is in the surviving sepsis guidelines, really only recommended for those patients who have persistent renal dysfunction or persistent slow clearance of lactate, possibly due to a poor EF where they need a little bit of boost from the beta to improve their cardiac output. But I don't use dobutamine a lot in my septic patients. I find it drops their blood pressure a lot, and then I have to bump up my Levophed, and then they get really tachycardic. So I don't use dobutamine a lot in my septic patients, but it is part of the sepsis guidelines. Other therapies, steroids and sepsis. This has been looked at in a lot of different ways, a lot of different trials, because a lot of patients in sepsis are adrenally insufficient, about 50%. We don't check random cortisols. We don't do court stims anymore. If patients are really sick, we put them on steroids. So here's a kind of a summary of the 3 most recent trials. There's Corticus from 2008, and then Adrenal and Approaches, both from 2018 in the New England Journal. And what you can see here is that in Corticus and Adrenal, there was no difference in mortality, right? Whether you got placebo or steroids. There was a significant reduction in mortality in the Approaches trial. And so you say, okay, what's the difference in this trial between adrenal and Corticus, where they didn't see a mortality benefit? Some people are like, oh, well, they got fludrocortisone. It must be the fludrocortisone. It's not the fludrocortisone. I mean, that's like a minimal dose. What it probably is that these patients are sicker, right? 50% mortality in the control group. So it goes along with what we're already doing. We don't give steroids. We don't give stress dose steroids to everybody with sepsis. We give it to the sickest patients, right? If you're on Levophed and now you're on vasopressin and you're like, oh my gosh, that patient's lactate's going up. They look like they're about to die. I need epinephrine. I'm thinking about adding a fourth pressor. For sure. If you're thinking about adding even a third pressor, that patient should be on steroids. Also, if they're on chronic steroids, probably somebody you should start them on stress dose steroids too. So steroids are not for everyone, certainly, but certainly for the sickest patients to try to reduce mortality. And then, of course, this is the other reason we use steroids is because if you get steroids in septic shock, you're out of shock sooner and you're off the ventilator sooner. All 3 trials have shown that. And then vitamin C. Vitamin C was a big deal when this trial was published back in 2017. This was a before and after trial looking at vitamin C and sepsis. So high dose vitamin C, stress dose steroids, and thiamine. It's a before and after trial where Dr. Paul Merrick compared before the vitamin C protocol to after the vitamin C protocol. And you can see a dramatic reduction, 40% mortality to 8% mortality in his vitamin C group. So once this came out, everybody was freaking out. We're like, we found the cure for sepsis. This is so great. All of these randomized controlled trials got up and running. So far, 4 of them have been published. Citrus, Ali, Vitamins, and Axe, all of which looked at different primary outcomes, but whether it was an improvement in organ function or mortality, no difference between vitamin C and usual care. And then this is the most recent one. This is the Victus trial from 2021 and out of JAMA. Again, now looking at ventilator and vasopressor-free days, no difference between vitamin C and the control group. So lots of trials. I think more trials will probably still be coming out, but I think as more and more trials come out, not showing any sort of difference with vitamin C, that vitamin C is going to fall out of favor, like most of the treatments for septic shock. So let's talk about that. So sepsis has been around for obviously a long time and has a huge mortality. If you get septic shock, there is a 40 to 50% chance that you are not going to survive. That is huge. That's higher than COVID. That's higher than MI. That's higher than lots of stuff. So you would think that with something that is so deadly, that we would have a better way of managing it. There have been multiple trials looking at management strategies for sepsis. This is just a few of them. What you can see here is that green is benefit, red is harm, orange is no difference. And if you look at all of these, there's only a couple green dots. And this is the early goal-directed therapy trial, which I already told you has been disproven. And then this green dot is the Prowess trial that used Zygris activated protein C, and that has been withdrawn from the market due to safety concerns. So out of many, many years of looking for treatments for sepsis, there has never been a successful treatment other than antibiotics. So then that makes us start to think about whether it is because we cannot treat every single septic patient the same way, right? Maybe there are different groups of septic patients and they need to be treated differently. Maybe there's something that we should start thinking about, like sepsis phenotypes. So a couple different studies, papers looking at sepsis phenotypes. This is a trial that we were part of. It was out of University of Chicago, where they did kind of retrospective chart reviews, found septic patients. So they found 12,000 septic patients, sepsis defined as infection with blood cultures and 4 days of antibiotics given. 12,000 septic patients at University of Chicago, 19,000 septic patients here at Loyola. And they looked at these groups of patients and they kind of lumped them into 4 different groups, looking at their temperature trajectory over the first 3 days of their hospitalization. They found that there were 4 groups. You were either febrile and slow to resolve. So they were persistently febrile. You were normothermic throughout your hospital, throughout the first 3 days. You were initially febrile, but then quick to resolve, or you were hypothermic. So 4 different subphenotypes that were similar in both the developmental and the validation cohort. And when you looked at these 4 different subphenotypes, they all had similar characteristics within each subphenotype. So the hyperthermic slow resolvers, these are the patients who are febrile and then slow to defervesce. They were younger, higher white count, higher inflammatory markers. The hypothermic group, they were older with more comorbidities, lower white count, more likely to be immunosuppressed. And so if you think about it, The hyperthermic slow resolvers is the hyperinflammatory phenotype. Again, higher white count, higher inflammatory markers. They have too much inflammation. Whereas the hypothermic group is the hypoinflammatory subgroup. They're immunosuppressed, lower white count, more comorbidities. The hyperthermic fast resolvers, the patients who are febrile to start but quickly resolve, is the well-balanced phenotype. So this goes back to what we talked about at the beginning. That balance between the pro-inflammatory and the anti-inflammatory response that your body has. If you have too much inflammation, that leads to organ failure. If you have not enough inflammation, that leads to secondary infection. But if you are well balanced, then you are at better chance of recovering from your infection, right? The pro-inflammatory kicks in, but then the anti-inflammatory response is like, whoa, watch it, and it kind of dampens it a little bit. So using that theory, you would think that which group would be the most likely to survive? That well-balanced phenotype, right? And that's what they saw. In both the developmental and the validation cohort, that well-balanced phenotype, the hyperthermic fast resolvers were the ones that had the lowest mortality. And the groups that had the highest mortality was the hypothermic group in the U of C cohort and the hyperinflammatory phenotype at Loyola. So super interesting, right? That maybe these groups are acting differently, but it doesn't have to have anything to say about treatment strategies. So that's what this paper looked at. This was looking at treatment implications within these different phenotypes for sepsis. Again, they had a derivation cohort and a validation cohort of septic patients. This is Chris Seymour's group again. And they, again, identified these 4 subphenotypes of sepsis. The alpha group, they were younger with lower SOFA scores. The beta group was the older group with more comorbidities and higher chance of having renal dysfunction. The gamma group had the highest inflammatory markers, and then the delta group was the sickest. They had the highest lactate, they had the highest SOFA score, they had more hypotension and liver dysfunction. So not surprisingly, the younger group with the lowest SOFA score was the group that did the best in terms of mortality, and the group that had the highest lactate and more hypotension, they were the group that had the highest chance of not surviving, right? So this is the hypotensive lactate elevated LFTs group. This is the delta group. But that's not the interesting part of this study. What they did here, and this is super cool, they took prior sepsis studies and using simulation models, they adjusted the percentage of phenotypes within the study to see if the treatment effect changed. So this is looking at, just for example, they did this for a bunch of different studies. I just took the process trial. So in the process trial, that was the one where they compared usual care to early goal-directed therapy. You can see that there was no benefit in the process trial. We've talked about that trial. And you can see the phenotype frequency was pretty well distributed between alpha, beta, delta, and gamma. But if, again, using simulation models, you adjust it so your entire study population is the alpha subphenotype, the younger group with lower SOFA scores. Hey, look, there is a benefit to early goal-directed therapy that says it increases the chance of finding benefit from early goal-directed therapy to 35%. So that's interesting. This study was a negative trial. But if you adjust it, so 44% of your population is that delta phenotype, that group that was high lactate, hypotensive LFT abnormalities, then the chance of finding harm from early goal-directed therapy goes up to 65%. So that makes you think maybe we can't treat all of these sepsis patients the same way. Maybe if we identify different phenotypes of sepsis and then adjusted the therapy based on their phenotype, then maybe we'd start finding positive trials. So for example, in the group that it has too much inflammation, maybe if we add some anti-cytokine therapy to reduce that inflammation and bump up the anti-inflammatory and make it more well-balanced, then maybe those patients would benefit. Whereas if there's not enough inflammation, then you stimulating the immune response by using GCSF or something like that, maybe that would make them more of a well-balanced phenotype. So it's just, I mean, again, this is too new of a concept to really, haven't been any randomized controlled trials, and it's hard to identify these phenotypes in real time rather than going back and looking through the chart, but something to certainly think about. So, oh my gosh, I'm way ahead. Look at me. All right. So in summary, sepsis is a medical emergency. It is so important to recognize the septic patient, that infected patient who's developing organ dysfunction. Use your QSOFA, use your Muse, whatever it is, identify those patients treat them urgently and emergently. Think about it like you would treat an MI or a stroke. It's a medical emergency. And the sooner you recognize it, the sooner you treat it, the better the chance that the patient's going to survive. Again, do not delay giving antibiotics. Don't wait for your attending. Just give the antibiotics, use that sepsis order set. A lot of times the antibiotics we have now are just available as IV push. So the nurse can just push the ceftriaxone or push the cefepime. It's in, it's done, not a big deal. And if your attending yells at you for giving antibiotics, then you can blame me. The 30 cc's per kilo fluid bolus, we talked about that a lot, right? Whether there's a mortality benefit or not, there's not a lot of data to support a mortality benefit, but I still think that a lot of patients will benefit from fluids, right? If you have to give a liter, it doesn't matter what you give. If you're giving a lot of fluids, balanced crystallose is probably better. The earlier, the better, right? Don't delay giving those fluids because the longer you wait, the more permeable the vessels are, the less chance that it's going to stay intravascular and have any sort of hemodynamic effect. Reassess your perfusion by using cap refill. You may not necessarily need to do like Q2-hour lactates to assess clearance. Norepinephrine is your first-line vasopressor because of the sepsis-induced cardiomyopathy. Again, the earlier the better. You can do it peripherally for a little bit if you really need to. So it's norepinephrine followed by that fixed dose of vasopressin. Hydrocortisone, stress dose steroids, 50 q-sick for our sickest patients. The patients who are on one pressor, you're adding a second pressor, you're thinking about a third pressor. Those are the patients that you should give stress dose steroids to. Vitamin C, I would say, is not recommended. And we have 4 trials, randomized control trials that show no benefit. I've never given vitamin C. I don't know a lot of people who do vitamin C. So I don't use it. And then this really interesting theory about sepsis phenotypes and how we should maybe change the way we manage sepsis. That's it. Questions? Yeah.
Do you have any thoughts as to why the mortality is different at Will and
Oh, the different phenotypes?
Yeah.
I don't know. I mean, they weren't dramatic. I think like one was 10 versus 9, and then the other was like 8 versus 9. So I'm not sure. We have similar patient populations, right? Transplant, things like that. So I'm not sure. It was interesting though.
You mentioned that vitamin C is not helpful. Was any of these trials had thiamine also?
They all did. They all did the Merrick protocol of stress dose. Never have. And the reason they use thiamine is because I think high dose vitamin C can induce some sort of renal dysfunction. And so the thiamine was used to prevent that. But also, you know, that there's been this thought about, you know, thiamine deficiency can lead to this sepsis-like syndrome, right? Like beriberi and things like that. And so maybe thiamine can be beneficial. I have no problem with thiamine, but I just never have used it. But in all those studies, they did the protocol, stress dose steroids, high dose vitamin C, and thiamine. Yeah.
When they were using the cap refill, was it binary? Like, was it graded? Like, okay, it was tracking it in terms of 3 seconds or more, or did they include looking at like 3 seconds, 5 seconds, 7 seconds?
I think it was just the resuscitation protocol was to target a cap refill of less than 3 seconds. I don't think they looked at adjusting the protocol based on how long it took. I think it was just a one or done. Yeah. Is there a chat that I need to look at? Oh, no, nothing. Any other questions? Yeah.
If you thought you did have someone who you did identify early as being in the high inflammatory type,
Yeah.
would you have a lower threshold to initiate steroids in that person?
It's such an interesting thought. I mean, right, that's what we kind of did for COVID, right? We'd be like, oh, you've got a lot of inflammatory markers, and so maybe you'd benefit from steroids and these cytokines. But I think it's really hard to identify those patients, right? Because I mean, they're all going to have high inflammatory markers, a high white count. But no, I mean, I usually wait until on a pressor or two, they look like they're about to die. That's usually who I do steroids in. All right. Thanks for coming, everyone.